morning, everyone. I'm going to take my watch off here because I don't want Tina out there going like this. She said she wouldn't do it out, but trying to make sure that I stay within your time frame. Thanks, Tina, so much, very much. You know, I hate to admit this, and I probably shouldn't, but this is always my favorite event to do every year. I love coming to the Rural Health Conference in the spring at French Lick. I gotta say, it definitely feels like summer out there right now, so I don't know that I've ever felt it quite this close and humid before. But it's absolutely awesome to be here, and most importantly, to be here to celebrate your 25th anniversary, which I think is so incredibly important. For a quarter of a decade, or a quarter of a century now, you have actually been bringing together clinical healthcare and public healthcare in your communities across the state to make sure that we can address those special issues, those special concerns, whatever those unique things that rural health experiences with regards to health, and address those at the table. And you know, at the State Department of Health, one of our main goals is that every Hoosier across the state of Indiana, regardless of where they live, would have that opportunity to be able to have their best health possible. And so we have appreciated our partnership so very much with Rural Health Association. I think it's been one of the best partnerships we've had, and I'm looking forward to another 25 years of that same type of partnership. You know, when Dorothy went off on that golden brick pathway, that yellow brick pathway, she was looking for the magical Oz who's going to help her to get home. And I think you guys might have a magician here coming at 1 o'clock who will probably do some really good motivational speaking for you. But the pathway, the golden pathway that we have, really, that your silver anniversary has put in place, that golden opportunity for health in rural health across the state, has already been lined. It's already been laid, the foundation of that. And many of the partners that have partnered with the Rural Health Association, our hospital systems, our healthcare systems, our elected officials across the state are present here today. And so once again, I really want to thank you for that opportunity for us to work together. You know, we have to talk about the challenges across the state of Indiana, and including in the rural areas across the state, to really understand about what our rural partners are facing across the state. I think whether those issues that are disparities across the state come from economic issues or come from lack of transportation or lack of access to care or whatever that disparity is, those are the things we need to address to continue to improve healthcare in our rural areas. We have to acknowledge those challenges in order to be able to understand what we're doing about those challenges. So today I am going to talk a little bit about the challenges, but most importantly, what I'm going to talk about is all of those amazing things that have been put in place and the things that are coming to really address those challenges across rural health. As many of you know, infant mortality is a passion of mine. I mean, I think quite clearly in 2017 when the governor hired me, it was really to address infant mortality and maternal mortality, certainly not the pandemic. In fact, I've heard from Hoosiers all over the state about why and you put your 4-letter explicative in there, is an OBGYN running our state at the time of a pandemic. And jokingly, I've wanted to say back that I ask God that every day. But I think I'm here for a reason, and I'm very proud of the partnering that we did across the state. I look and see many of our healthcare professionals that we worked with to make sure that we were delivering what Hoosiers needed during that pandemic. But when we look at our infant mortality rates, and you can see Indiana there in the navy blue, we had our lowest infant mortality rate in 2019 at 6.5 infant deaths per 1,000 live births. And since we started recording that in 1900, that's the lowest we've ever been. In 2020, we ticked up slightly to 6.6. But if you look at our Hispanic, which is in the green infant mortality rate, and our non-Hispanic white infant mortality rate there is in the light blue, both of those rates actually fell in 2020. It was our non-Hispanic Black rate that ticked back up after a couple of years of significant declines down to 11, back to 13.2. And I think the important thing to recognize is that's 2.4 times the white infant mortality rate in the state of Indiana. And that's particularly distressing and disappointing because of the work that has been done in and by our Black communities across the state of Indiana to address this. So it just continues to make it clear to myself and other people in this room who work on maternal child health the importance of directing our programming and our policies and everything toward these most disparate populations. When you look at the causes of infant mortality, the number one remains perinatal risks, which are those risks associated with preterm birth, premature rupture of membranes, bringing that preterm baby into the world, and then what preterm babies die from. So all of those ICD-10 codes, which include sepsis and overwhelming respiratory failure and NEC. And that is the number one cause of death in Indiana for infants and across the United States. But what I want you to look at is that navy blue for the non-Hispanic Black population. That 6.1 of their infant mortality is related alone to preterm birth for the most part, and those complications of it. And that in itself is higher than all the causes of infant mortality for non-Hispanic white, which is the next column to the right, and for the Hispanic population. If you also look at, and what that says to me is that there are issues that remain in our non-Hispanic Black population that we need to get way upstream for. We need to improve maternal health and access to maternal health and contraception and planning for pregnancies and everything else that goes along with supporting non-Hispanic Black women as they go through their life as a woman and have pregnancies and raise their families. But also, our second cause of infant mortality across the state of Indiana is now genetic defects. It used to be sudden unexpected infant death syndrome, but for a state as a whole, it's genetic defects. And when you look at genetic issues, a lot of people say to me, well, I can't do anything about that. But the reality is you can. You can give women prenatal vitamins and make sure that they have extra folate so we decrease the risk for neural tube defects. You can make sure that women get into care, and we can look at the medications that are prescribed for them that may actually cause birth defects. We can address the substances that they're using that could be harmful to the baby. So there's a lot we can do in that space, but we have to see women at least in the first trimester and preferably even prior to pregnancy. And then the third cause is sudden unexpected infant death syndrome, the large majority of which have a component of unsafe sleep associated with them. So our messaging is resonating with some of the population across the state of Indiana, but it's still the number 2 cause of death in our non-Hispanic Black population. So either the message isn't resonating or we're not reaching the right people. We're not reaching the people that are putting that baby to sleep in those non-Hispanic Black families. Maybe that's grandma or grandpa or auntie or uncle, or maybe it is a local caretaker that they're using. But we need to continue to address that. Now, My Healthy Baby is a program that we developed in 2019, right before the pandemic, and actually started rolling out in 2020. And this program is specifically designed to connect more women early in pregnancy to a home visitor or family support provider, because there are decades of evidence around the fact that this improves maternal child outcomes. So we have rolled out in our first year to 22 counties, the counties with the highest rates of infant mortality, sudden unexpected infant death syndrome, preterm birth, etc., and to women who are covered or eligible for Medicaid. By the end of this year, we will be in all but 10 counties in the state of Indiana, and the last 10 we have the lowest risks associated with them, but are still very important. So by end of first quarter or mid 2023, if you are a woman covered by Medicaid or eligible for Medicaid, you will be able, if you desire, to be connected to a family support provider or a home visitor in your own county. So we refer into programs that are already existing. We're very lucky in that the preventative arm of DCS, called Healthy Families, actually has programming in every county. They have people in every county. And what I will tell you is that the problem we're running into now is that we are filling these programs up because this program is resonating, especially with our highest risk communities. So I'm going to need to be going back to the legislator to see, number one, how can we go forward and financially support this by reimbursing Medicaid for nurse-family partnerships and community home visitors and healthy families, and how do we expand these programs? Because I want to expand that not just to Medicaid patients, but but also to any family that is struggling to be able to put food on the table, keep a roof over their family's head. Because we know there are a lot of two-income families out there that healthcare has to go by the wayside because they can't afford it, or they have such a high deductible that they can't afford to go and get the care that they really need to have. IRHA, oh, I'm sorry, one thing before that. How can you help? Talk about the program. Talk about it with elected officials, with community home visiting. What is your home visiting in your county? Find out, do they need more? Are we connected? If there's a disconnect, let me know about it, because the most disappointing thing to me that I tell everybody around the state is if I come back and find out that it's not successful in your county and you say, we knew that would never work because of X, Y, or Z, I'm going to be so disappointed, because my email is open to anyone who wants to email me, and I will connect you to the right resources, and we will do our very best to correct whatever that issue is. And you can see on this slide the ability to connect women. Women can call, connect themselves. You can connect a woman. You can get online. They can actually sign themselves up online. So there are all different options to do that. And that phone number is our My Healthy Baby helpline, or our mom's helpline. So we can connect women, even women who aren't covered by Medicaid, even women who don't qualify for the Pregnancy Promise Program, which I'll talk to you about. We will know resources available in the community to connect that woman to. This shows you that Nurse Family Partnerships is a very important part of this across the state. They do a great job servicing probably around 2,000 women per year, women that are with their first baby and seen before 28 weeks. They would like to expand to every county. Certainly their outcomes are absolutely amazing. But it also talks about IRHA's Healthy Start program, which is really, really important, and is already available in Davies, Du Bois, Greene, and Martin counties. And we've used that as connecting referrals for My Healthy Baby. I'm sorry, I might have been a slide behind, I apologize. This slide shows you that one of the things I recognize very clearly with 35 counties that either have no hospital or the hospital has no inpatient obstetrical services, that there were areas of our state where, because no inpatient obstetrical services were available, we lose women's health care. We lose following up an abnormal pap smear, contraception, making sure they're getting their mammograms, making sure that they're seeing people preconceptually for their care. And so even though we have a lot of family doctors in our rural areas that do this, many of them don't do obstetrics. So part of the My Healthy Baby money that we got that first year, we actually granted out to Logansport Hospital, Union Hospital, IU Health, and to Southern Indiana Community Healthcare, to actually branch out into those counties around them that don't have inpatient services and provide obstetrical care and women's health care in the counties closer to the women, sometimes even in the homes. These programs, I'm really happy to say that even as the grant ends, they're continuing these programs forward because they have been successful. And so the State Department of Health is committed to growing those and continuing to grow those through grant programs. And I think that's what we need to set up. I will tell you, having worked with advanced practice nurses and nurse midwives, they are great outreach individuals, and they bring more patients into our hospital system. And I know Vigo County is already looking into that. So I'm really, really excited to see that happen across our state. I also want to mention that everyone's probably aware, but I hope they're aware, that IRHA has the ability to connect families and pregnant women and children to healthcare coverage through the Connecting Kids to Coverage in Indiana. We also use the Covering Kids and Families across the state of Indiana, because what we find is that oftentimes presumptive eligibility gets filled out, but the actual application doesn't get finished, and then they lose their health care, they lose their support. And so what we want to do is facilitate that, and these programs do that very well. My Healthy Baby, we've also trained people at the Department of Health in navigation for these healthcare systems, and will actually help complete or start that Medicaid application also for women. I want to give you an update on where we are in perinatal levels of care, another thing that our legislators voted through and funded, and we really have been excited about the fact that we are going around to every hospital that delivers obstetrical care in the state and certifying them as far as their level of infant care or neonatal care and their level of obstetrical care. So that could, for obstetrics, be 1 through 4. It could be 1 through 3 for our newborn units. But the bottom line is the goal here is to make sure that when a woman or a baby has risk factors, that they deliver at a facility that is equipped to manage whatever those risk factors are. We have now completed that designation in 96% of our hospitals. We have 2 hospitals left, and I'm so excited about what's happened in this space. And this has been shown evidence-based to improve the health of moms and babies. I think what's really important and what I'm excited to talk about is one of the big successes of this, and that was a program that was at Baptist Floyd in southern Indiana. And they asked to be designated as a level 2 OB and a level 2 neonatal. When we went in and did the assessment in April of 2021, they were designated a level 1 OB and a level 1 neonatal. But at the same time we gave them designation, we showed them where they fell short and what they actually needed to do to be a level 2 at both of those. One of those that you have is that you have to have a car seat safety program so that we can show that those newborns, especially those preemies when they go home, are safe in a car seat, that they're not going to have their head down this way and potentially suffocate. They are actually connected to their Baptist Health in Louisville. They already had a complete program for this, so they instituted that program in their hospital, trained all their employees, and then they went around and made sure that every respiratory therapist was trained for neonatal resuscitation, which is really important, and make sure that there was more of a presence of those respiratory therapists on the unit. And lastly but not least, they needed to offer regular education offerings to their staff, their OB staff and their nurses. And so they did that, and when we went back and we resurveyed them, they are a level 2 too. So this is an example of how these perinatal levels of care is going to help to raise care all over the state, and sometimes it's just by a few simple tweaks that we do. The S.T.A.B.L.E program is really important. I've been talking a lot, even to National ACOG, about the fact that we need a level 0, meaning we're a hospital, we have an emergency room, we're going to have pregnant, postpartum women, newborn babies come in with complications, and we're not going to be prepared for it because we don't have the staff that we can call down from upstairs from labor and delivery. And S.T.A.B.L.E is a program that's probably the most widely spread and implemented program across the state. So some of the Indiana Department of Health people have gone out and gotten trained, and we've been partnering with hospitals to actually train on S.T.A.B.L.E in emergency rooms and in hospitals across the state. Specifically, they look at sugar, temperature, airway, blood pressure, and lab work, and then emotional support, of course, for the family that is sitting there. And this is a way to make sure that you can not only resuscitate the infant, but stabilize them and then transfer them. I'm really happy to say that we've been working with hospitals around the state, and we'll be up in Pulaski County. As you know, they recently dropped their obstetrical services inpatient. And I think this is a really important part so that we are prepared in hospitals, critical access hospitals all across the state. I also want to talk a little bit about using technology to make sure that we are addressing healthcare issues in our rural areas. We're seeing that technology is really expanding our reach across the state. The Department of Health, as you know, has the Live app, which is for women who are pre-pregnancy, pregnant, post-pregnancy, in any stage for resources, connection, or further education. This IU Health in their East Central region, so Muncie would be their hospital, but are partnering, working in Blackford and Jay to provide this Baby Scripts app. And it's really a virtual care platform that they're offering to all of the providers for obstetrics in these counties and areas that helps to continue to connect women to care and connect across the platform. And then the deliveries are done at Ball Memorial Hospital. And they were one of the grantees for the outreach into the counties surrounding them. So I think we should all continue to look for innovative ways, especially through technology, to connect rural Hoosiers to care. As a part of Indiana's approach to address maternal deaths, especially those deaths that have been associated with violence in our communities, our Fatality Review and Prevention Program partnered with Maternal Child Health and actually received a grant federally for centering pregnancy and centering parenting that can be done at 5 different pilot sites. And this is really group prenatal and postnatal support and family support. And that's really important because families and women need the support of other families and women that are in the same position. So this connects them to education, support systems, further health care, and makes sure that they're getting the resources that they need to be successful. I'm going to talk just a little bit about maternal mortality. I believe that the programs I've already talked about, and some that I won't have time to talk about today, are not only going to help infant mortality, but they are going to improve maternal morbidity and maternal mortality, just by the nature of the fact that we are introducing the support system into this family. When you look at the slide, just a reminder, maternal death is the death of a woman during the pregnancy or in the first year after her pregnancy ends. It could be a pregnancy-associated death where she dies of something that has nothing to do with the pregnancy, like a motor vehicle accident or an overdose could be a part of it. Or it could be a pregnancy-related death. So it could be something that is an underlying health condition she had that was exacerbated by the pregnancy, or that started new with the pregnancy, like a blood clot that went to the baby's lungs. Most importantly, we just finished our second maternal mortality report, and I say we, but I will tell you that Dr. Mary Abernathy, sitting at this table right here, is leading that team of professionals from across the state, and Indiana is just absolutely nailing it. I mean, we are doing an amazing job reviewing absolutely every maternal death that we can find. In fact, this review is so in-depth and so complete. It is such much better data than what we used to get in the past, and the method we are using to identify a woman as having had a maternal death is so much more accurate that I can say to you it doesn't even begin to compare to the National Vital Statistics System data that's out there. So it's really important that we continue to do this and that we continue to fund this going forward, because when we know what women died of, we can go back and implement things in communities where these deaths are occurring to change the risk for the next woman to die from that. I get talking. Sorry. So this is actually the slide that shows you in the pale gray the counties that have hospitals but no inpatient OB services, and then the counties that in the dark gray have no hospitals. And I think what I want to mention here is that even though the bulk of our deaths are occurring among women living in metropolitan areas, and that's because the bulk of our deliveries are in women living in metropolitan areas, we did have about 13% of our deaths from women living in our rural areas across the state. And that the rate of deaths of women in these rural areas is actually higher than the rate of births in these areas. It's about 9.4% in these 2 years combined. Now, this is a small data points, small numbers, so I don't want to take anything big away from this, but I do think it indicates that there's probably a trend or a disparity here, and something that we're going to need to address, and making sure that there is obstetrical care and connection in all of these counties. Nearly 1/4 of our deaths actually occurred among individuals who received no prenatal care. And of these maternal deaths, 45% of women, only 45% received care in the first trimester. So we really have to do better at finding these women wherever they hit our system and engaging them and making sure that they can get connected to a home visiting program through My Healthy Baby or your rural programs or whatever, so that we can go along and follow them. Also, we know that over 50% of these women were covered by Medicaid. I think the thing that's absolutely overwhelming to me, and I want to, if you don't take anything away about maternal mortality than this, that I want you to remember, is that when we looked at the combination of 123 deaths in 18 and 19, overwhelmingly, 33% almost died of maternal overdose. And when we looked at actually maternal substance use disorder, it was deemed a primary or a significant contributing factor in over 51% of those deaths. Then when you look at pregnancy-related deaths, we had the usual hemorrhage, sepsis, cardiomyopathy, embolism. And so Indiana is an AIM state, meaning that the Alliance for Innovation in Maternal Health, which is supported by IRHA, helps to embed safety bundles in hospitals to address each of these issues, and we work with our labor and delivery units to make sure that they're there. We've already done hemorrhage and hypertension, and we're combining our perinatal substance use disorder toolkit with AIMS substance use disorder, and we'll be rolling that out soon. FSSA has done an incredible job, I think, of continuing to follow up, and they developed something called the Pregnancy Promise Program. They were one of only 8 states in the nation to receive this 5-year grant, and the grant, most importantly, has developed a program that is completely voluntary and it is completely free. to any woman who has a history of opioid use disorder or ongoing opioid use disorder, and she is eligible or covered by Medicaid. Now, a lot of people ask me, well, what about the woman that is using crystal meth? Well, first of all, if you're using any drug these days, it's very likely that it's laced with fentanyl, and that's why we're having so many overdoses. And most women who are currently using drugs or have used them in the past have used opioids at some point. But if this person doesn't qualify in your mind at all for this program, you still refer them to the program because we will know resources available to help this woman in her community. It's being administered by the managed care entities, and basically they're using an enhanced case management rate and basically have less individuals to follow, and they're using nurses and they're using licensed clinical social workers to address this. And most importantly, making sure that that woman is engaged in prenatal care, not just engaged, but attending prenatal care, that that baby gets into care, to make sure that that baby gets on case management, to make sure that there are peer recovery coaches attached to these women, that they have the access and they're going to their substance use disorder treatment appointments and their mental health appointments, and make sure that all the services that they may need, the resources that become, in our minds, maybe small barriers, but are huge barriers to them to be able to continue to engage in this care, are being addressed. Medicaid also did something that we've been working on since I started in 17, and I'm so happy about, and that is that we extended postpartum coverage for women covered by Medicaid at the time of their delivery for a full year afterwards. And that's not just for pregnancy care. Yeah, thank you, Ann, and other legislators that might be here. That allows us to identify a problem during pregnancy, like substance use disorder or mental health issues or diabetes or high blood pressure or abnormal pap smears, and make sure that we get that woman on a better path to care for whatever that issue is. And the other things there were just kind of cleanup. Medicaid was already doing them, but they needed to officially go into statute. I want to talk a little bit about substance use disorder and harm reduction. My team was like, I don't think you should talk about that because there's nothing good to say about it. But what I'm going to tell you is that to not mention this would be a huge issue, because you all know what a huge issue it is. When we look at having that brighter future, we have to know what the issue is and know what the problem is. And my belief when it comes to substance use disorder is we are going to have to start to invest more upstream in prevention, addressing ACEs, addressing that trauma that exists in people's lives, and the mental health issues that make them reach for substances to try to treat this problem. But after seeing the number of overdose deaths actually decline from 2017 to 2018, we saw a huge jump in 2020. In fact, some of our counties jumped as much as 700% for overdose deaths in their counties. And while the numbers did drop in 2021, we still lost 1,600 Hoosiers from overdose that year. 1,512 of them were directly related to opioids. I do have to talk just a little bit. There is the graph of the of the years, and you can see the huge jump in 2020. When we look at this challenge, we have to recognize the existence of fentanyl and the difficulty in testing for all the synthetic fentanyls. Every time we get, a particular panel ready, then they add a new drug or they change it just slightly. But the bottom line is fentanyl is what is killing our Hoosiers overwhelmingly. When we look at this, fentanyl has been called the weapon of slow mass destruction. And it is slowly mass destructing our state and many states in the United States. And so that's why Indiana has started very much emphasizing harm reduction across the state. Our approach has always been, the governor has been very supportive of this. It's a multi-agency thing, and obviously our drug prevention, treatment, and enforcement team is led by Doug Hunsinger. I'm sure many of you are very familiar with him. But the focus has always been assessing where each individual person is and then bringing the resources to bear based on where they are. We are specifically now partnering with our court system to make sure that they have the ability to connect more individuals that hit the court system with substance use disorder and mental health support, hoping that we don't see them repetitively back in the courts, because we know this is a place to have access. We've strengthened our recovery support across the state. They ensured that Medicaid would pay, people covered by Medicaid would have access, and that's 1.6 million Hoosiers in our state. We decreased opioid prescription rates across the state by 23% and made it easier for professionals, clinicians, to actually go to the chart, click on a button, and there you go. You've got their prescription history with regards to opioids. So to my mind, there's no excuse for writing an opioid prescription for someone without knowing what their history is with that. And then we've increased residential treatment beds. When you look at harm reduction, some of those harm reduction sites include syringe service programs, some do not. Importantly, we're trying to screen for underlying health conditions like hepatitis C and HIV, which go hand in hand with the IV drug abuse. In November, we actually deployed 10 harm reduction mobile teams so that we could send them directly to hotspots or areas where we saw increased deaths from fentanyl and other things. Through our partnership with Overdose Lifeline, and I know there are many people engaged with us here today, we have actually distributed now 128,000 doses of naloxone, and there are 19 naloxone vending machines in areas of high need and high traffic, and 430 naloxone boxes, especially situated in our rural areas across the state. We've also been through grants through the Drug Prevention and Treatment Program to communities. We've granted the 21 communities to coordinate development of that trauma-informed care and the recovery-oriented care as a system that need to be present for our judicial system, because we hear loud and clear that so many of the people that they're seeing have substance use disorder-related issues. Indiana will likely receive that $507 million, which is the full grant, not grant, but money from the state and the settlement for the opioids. 50% of that will actually go to local state government and 50% to the state. Of course, we are requiring or asking that all the money be used in some way for drug prevention and treatment within the communities. I know I don't need to talk much about this, so I'm not going to spend much time, but I do want you to know that the Paramedicine program or the Mobile Integrated Health program with Paul Miller and his team have oftentimes talked to you about is expanding. We have 20 programs now across the state of Indiana, mostly in rural areas, not always. We are continuing to expand those. We have some with our 1007 health grant that we'll be helping to fund. And IRHA has actually been working along with United Healthcare to develop the community paramedicine program around maternal child health. So that would be something that once you start a paramedicine program could be implemented within the community also. In addition to substance use disorder, or hand in hand with substance use disorder, mental health issues in our state have increased significantly through the pandemic. I know that is no surprise to anyone. And this is affecting Hoosiers of all ages. There are some bright spots in this, and one of them is, to my mind, is that the Youth Risk Behavior Survey that we like to do every other year in combination with the CDC for the first time since 2015 has weighted data, because our team personally, myself included, called the last 8 to 10 schools that we really needed to get engaged, because they're randomly picked, so we don't get to choose a different school. And they're randomly picked to make sure we are representing urban and rural, and we're representing suburban, we're representing the non-Hispanic Black and the Hispanic population. So that's why we have to be so careful. The Governor's Public Health Commission, to my mind, is probably one of the greatest bright spots that we have in the state of Indiana, and something that I would ask support from every single one of you, and it's going to take support from every single one of you to get this passed with our legislators, because you know public health right now is not a favorite topic for a lot of people, and I understand that, but public health is so much more than what you saw through the pandemic, and I think we really, really need to emphasize that point. The Department of Education is also working on increasing mental health support in schools, and the FSSA Division of Mental Health and Addiction actually got $100 million of the ARP funds to be able to address substance use disorder and mental health. Just some brief information about accidental deaths in Indiana. You can see the overall accidental deaths in the blue line here, and the significant increase from 3,876 to in 2020, 5,500 or 4,580. And then you can see the red line, which was documented suicides. Again, that was up from 972 to 1,024. And then the green line, which are those that we just really couldn't determine suicide, accidental, when it happened. When you look at crude suicide rates by race, ethnicity, and gender, men, unfortunately, are winning this race every time. When we look at non-Hispanic white men, they're the highest rate in green at about 27.7 per 100,000 non-Hispanic white men. If we look at the non-Hispanic black men in red, it's the second highest, but what I really want you to notice is that they had the highest rate of increase from 2019 to 2020, from 14.2 to 18.3 per 100,000 individuals in 1 year. And then Hispanic men in the orange. The only women that actually made this chart were the non-Hispanic white women, and their rate was at 6.3. The non-Hispanic black and Hispanic women actually were suppressed because of their lower numbers. As I mentioned, for the first time since 2015, we have this weighted data with the Youth Risk Behavior Survey. You'll see us presenting this at the Children's Commission coming up, and I'm going to present it, or part of it, at the school health nurses. But this data will be available to all of you. You can ask us, we will send it to you. We have developed slides on this, and we want this data circulated widely so that people have the opportunity to know what this data shows. It's a random survey of schools completed every other year. In the odd years, we completed ours in April of 2021. And the data allows us to be compared not just within the state to our past years, when we have weighted data, but also to other states. Now, there was a delay in many states. They didn't do it till the fall of 21, so I don't have the state comparison yet, but I will have that shortly. I think the biggest takeaways is that we saw tremendous declines in youth cigarette use or smoking, and basically the percentage of students that were drinking alcohol. Although vaping was less than in 2015, we still had almost 20% of our seniors say that they were vaping. That's 20% of the population going forward at this age that will probably be addicted to nicotine. We also found that the biggest takeaways were in mental health issues. And honestly, when I want to comment about that data, I believe, unfortunately, because we've seen substance use disorder go up in kids and their risky behaviors, that they're substituting marijuana and other substances for alcohol and for the nicotine in cigarettes. But the biggest takeaway is that mental health issues were significantly on the rise in Indiana in our youth compared to 2015 and 2019. Not unexpected, I understand, because of the pandemic. But in 2021, nearly 50% of students said that they felt sad or hopeless almost every day for 2 weeks in the past year. And 11% of them said they had attempted suicide at least once or more than once in the prior year. And that 50% is higher than the nationwide 2019 data of 37% and higher than Indiana's 2015 data of 29%. It was very clear we have a lot of work to do, and we need to provide mental health support in our schools. Kids need to be able to come to school and learn. And if you talk to teachers, when a child comes to school and they've been abused or they've watched someone use drugs or whatever else is going in their life, they are not prepared to learn. And when only 53% of our high school kids are going on to college to further after school or after high school education, 46% among males, 60% among females, that's recent data. That's huge and something that we have to address, not just for our workforce and our economy, but for individuals across the state of Indiana. I'd be remiss if I didn't talk a little bit about ending the epidemics here in the state of Indiana. I want to share a quick update about where we are in progressing toward that. We know that this has been an issue across the entire state. It goes hand in hand with IV drug use, but especially in our rural communities. Indiana was at one time, just about 2 or 3 years ago, I don't remember the exact year, we had the #1 highest rate of acute hepatitis C in the nation. We are now, based on the resources that we brought to bear on this, the coverage from Medicaid, the extension of care across the state of Indiana, and the screening across the state of Indiana, we are now one of the top 6 states in the nation that have been voted most likely to eliminate hepatitis C by 2030. So that's huge. It's something we should be proud of. We've also increased linkage to care and viral suppression and more case managers, and we'll be continuing to increase case managers in HIV around the state of Indiana. So that Indiana's plan to end the epidemics of hepatitis C and HIV really can become a reality. And in case you see it, that 0 is possible, that's what the programming that it's referring to. Another thing we have to thank our legislators for is the Health Issues and Challenges Grant. This was ARP money, so American Rescue Plan money, that the legislators and Ann Vermillion, Representative Vermillion, was huge in this across the state. So I'm really, really proud. Thank you, Ann, for that. But basically what they did was they granted $50 million to the state of Indiana that we would then grant out to programs to address some of the major healthcare issues and poor outcomes in the state of Indiana. So programs that address food insecurity and obesity, programs that address lead exposure in our children, nicotine, addiction, prevention and treatment, hepatitis C, chronic diseases, increased cancer screening, improvement and increasing community health and workers and paramedicine across the state. So I'm really proud to say that as of this week, we'll be announcing $33 million that is being granted across the state of Indiana to 150 different organizations across the state. And when you look at the map of the programs, we've represented the state. You have represented the state pretty well. I'm really excited about the paramedicine and community health workers, especially for our rural areas. And we've provided a significant amount of that funding to our local health departments because the state of Indiana is going to get with the CDC recommendations of 3.5 micrograms per deciliter for lead. Really, no lead exposure is acceptable. You and I and our grandkids and our children would want that level to be 0 every time. But we need to get that level down. We're at 10 right now, and we've got to get with the program and start offering services to these children across the state. Again, I always say, work so hard to bring these healthy kids into the world and keep them healthy the first year of their life. We have to continue to protect their intellect and their ability to pay attention as we go forward. Oh, there we go. I'm behind again. Sorry about that. But Tina will be glad to give all these slides to you guys if you want them. And lastly, I just want to take a few minutes to talk about the Governor's Public Health Commission. From the first year that I came here, the first thing I did was I traveled to every local health department in the state of Indiana. And it was very clear to me in 2017 and 2018 when I finished this up, that where you live in Indiana really did determine the access to foundational public health services that you had. And then came the pandemic, and that further highlighted that issue, that lack of funding and lack of workforce and support in many of our areas across the state, really across public health in every county and at the state level in Indiana, affected our ability to have the workforce we need. Now, lots of people stepped up. Our hospital systems, the Indiana National Guard, volunteers, a tremendous number of people, and I think we did an amazing job of responding to it. But it uncovered a lot of issues that the state of Indiana and really many states around the nation have had. You know, the life expectancy in Indiana has been declining since 2010. And data in 2019 showed that Indiana's life expectancy was 77.1 years, which placed us 40th in the nation. Most importantly, it's 2.1 years behind the national average of 79.2 years. And I think even more telling is when you look at every county's life expectancy, the difference between the county with the highest life expectancy and the lowest is almost 9 years. And many of the counties suffering from those lower life expectancies are our rural counties. And so we have got to get upstream and we have got to address health and healthy living and have the ability for people to have the exercise and access to the healthy foods and the health care and the ability to be able to get their numbers checked, to know what their cholesterol is and their blood pressure is and all of these things that are so important as you go forward. Screening for cancer. Oh, it says battery is running low. So you may want to plug in your PC. Do you have a way of doing that? Or I can just keep on talking while you do it. No big deal. So when we look at our health departments, we have 94 local health departments across the state of Indiana. 90 of those local health departments are county-based. One is a combined county of Fountain and Warren, led by Dr. Sean Sharma, who does an amazing job up in those counties. We have 3 municipal health departments, so East Chicago,